Hello, now we will talk about diabetes care. I'm here with Andrew Boulton, professor at the University of Manchester, Xavier, professor at the University of Barcelona, and Leszek, professor at the University of Warsaw. So what is the reality now of diabetes care, especially in primary care today, and what are the challenges?
I think nowadays in primary care, we're dealing with a big epidemic. I think it depends on in what country you are, but we have a lot of our patients coming to our offices that have diabetes as a chronic condition. And we know nowadays that chronic conditions are not just diabetes, it's a big challenge in clinic. So we have around 8 to 10 minutes per contact. We have to facilitate as much as possible how our colleagues can be dealing with this chronic condition in real life. And I think there are many aspects we are trying to cover. Early identification of our patients, like primary promotion of health promotion, then primary prevention of health promotion. We also try to identify early these patients, also to start treating them earlier. And also we have now new tools in some countries in clinical practice with electronic clinical records that are helping clinicians in terms to improve quality of care in our diabetic patients. But there are many areas we are trying to cope in primary care nowadays, and taking into account type 2 diabetes management. Yeah.
I think we forget that across the world, in most countries, type 2 diabetes is obviously above 90%, especially in Asia, and the vast majority of patients are looked after in primary care. And we forget that, and I think it's so important that we work very closely together, and we should be talking about prevention. Primary prevention is identifying the patient with high risk of diabetes. We can't do total population screening, but the patients with obese, with a certain ethnic background, with a family history and so on, if you've got diabetes, we should be secondary prevention. Preventing the development of complications, not only by controlling blood glucose, but hypertension, lipids, all these factors. And primary care is looking after most of this, and it's a delight to have primary care involved in this meeting.
Yeah.
There's one other issue that what we know from the last decade is that primary care treatment at this level is crucial for prevention of long-term complications. So I usually say that we live in a kind of a paradox times, because we change the accent what we put or which care is more important. For years, or in every specialty, the specialists say, okay, we're important, there is somewhere the primary care, they do the prevention stuff, but the real, when things are going on, are in specialist clinics. In diabetology, it's exactly reversed nowadays, because we now understood that what primary care physicians can do or can't do affects the risk of long-term complications vastly. The first 10 years, probably, since the diagnosis, are crucial for the whole future life of the patient. And we don't see these patients as diabetologists. They are seen and cared for by primary care physicians. But that also means that primary care physicians need education forces, resources, nurses, time. Someone has to pay for it. Just for that in next 20 years we have less and less complications. When a patient comes to us with any sort of complication already developed, even at its very beginning, like constant macroalbuminuria, it's basically too late because something has been lost. So for us, I can say that in Poland we try to cherish primary care physicians in terms of diabetes care. We developed collaboration between our associations, national associations, and fortunately we have strong support from the Ministry of Health, who he's in his post for a year and a half now, and he's a primary care physician, so he fully understands that.
I think that's a key point. I think it's clear that in Europe, many countries like UK, the Netherlands, Denmark, Finland, Spain are already centered there as a primary care as a first point to take care of the citizens. And all of these programs of primary prevention are well established in the last 25 years or 30 years. And now also in those countries, emerging GPs or healthcare professionals in primary care, not just GPs and nurses with a special interest in diabetes, has been developing continuous quality improvement programs in terms to explore what has to be improved, and then to do actions. For example, there's a lot of actions in diabetic food, like screening or eyes referral, and there's clear examples. For example, they are developing guidelines. For example, Netherlands have a lot of nice guidelines. Also, the UK. Also, I remember in Finland they did a program from the 2000 to 2010, the DECO, where they would like to, from primary care, they would like to work strong in terms of improving care to all citizens in Finland with type 2. So I think that I fully agree with what you're saying. I think it's very important to create bridges between secondary care and primary care and try to see in a patient-centered approach what we can offer better according to different healthcare systems, because we are in Europe or we are having this pan-European vision, but we have sometimes completely different healthcare systems. We are Spain, from Italy, or from, for example, France. We have completely different healthcare systems, but we have to try in that healthcare systems what we can, from our places, we can offer the best approach for our citizens.
Well, in UK, in the Netherlands, you're quite a few steps ahead. We look at the Dutch example very much, also the British one, where in the Netherlands over 90% of type 2 diabetes patients are looked after by GPs basically. But it didn't happen, well, overnight, but it didn't happen because really doctors wanted it. It was a structured decision by the Ministry of Health. It was also politics involved in that. And that's what we try to achieve in our part of the world.
But I think it's reasonable that a chronic condition with really high prevalence has been taken into account in the closer area where this patient can be managed. And I think that this big epidemic we have right now is not possible to be probably tackled in those like specialists. I mean, specialists at secondary care. I mean, at hospital level, because it's a so amount of citizens with a chronic condition that probably requires more human resources to be covered at the specialist level, considering hospital. But of course, I think that now we have to work strong to create that bridges with secondary care and primary care and shared care, looking for new ways of communication. We are exploring in many countries, like where probably healthcare systems don't allow that, creating like some telemedicine, shared care, and new technologies. And I think that they bring in opportunities to better care in those situations.
But there are other obstacles, like, again, I will use Polish example, like patients' mentality, because for years GPs were not really that respected by the patients in my country as they should be. So, and the patients usually say, okay, I have diabetes, I have to go to diabetes specialist. I have coronary heart disease, I have to go immediately to cardiologist. So the patients would rather stream into the outpatient specialist clinics, which are never enough and which are always full. So now we try to reverse this trend. It will take a decade at least.
And it's difficult because, for example, in Belgium, where the citizens have the right to go wherever they want, it happens the same time in your country. And Belgium have a long story in primary care, very introduced in the academic, and they are doing a lot of research projects, but the primary care physicians from Belgium, they feel very isolated to try to be responsible supporting type 2 diabetic patients, because the citizens have decided to go directly to secondary care. But those systems like the Spanish system, the UK system, the Netherlands, from the Dutch system, Danish system, are already centered from primary care as a first step. And I think they are working really nicely in that perspective. And there is many projects and research already published that provides the benefits of following from many angles of the disease, what could be the benefits of being providing that care at that level.
But you raised a very good point earlier, and that is the key role not only of the physician, whether it's primary or secondary, but the team.
Of course.
And one link between primary and secondary care is specialist nurses, nurse educators, whatever you call them, a diabetes specialist nurse in the UK, and they often work across primary and secondary care, and that's a great way to bring together the two, and not only them, dietitians, podiatrists, if you have them. This is the key, I think, to the future, the team approach, and a bit like Orwell, we all should be equal.
Completely agree with you, and also something where we know that we have to improve now, and I think countries are already advanced for that, is we have to have like a standardized educational programs, because we are all the time talking about education, but everybody's providing education how they consider it is a good thing. But already there are some programs that have some research behind that supports the benefits of that approach. And I think that is an area, there's a lot of heterogeneity in primary care. And in my country, for example, we don't have diabetes educators in Spain. Right. Yes, they have, but at hospital level for type but not for type 2. So I think it's
the same in Poland.
so it's important to introduce a good portfolio of lifestyle. I mean, not just diet or education in diet, and education also in physical activity. That's also, we are all the time talking about physical activity, but we have to prescribe physical activity, how to prescribe physical activity. And this is a big thing we have to improve, I think.
Yeah, but I would stress once again that now this approach of moving more resources and putting primary care more in the focus in diabetes care is strongly reinforced by the evidence, the data from the studies. It started with the Accord study, which showed that if we treat more intensively the healthier patients, then we will have the better results in preventing complications. And as I said, in my country, I very rarely diagnose diabetes. Yes, it happens only in hospital where we have patients with other diseases. But you as a primary care physician, you must do it almost on a daily basis, I believe, yes, because this is so frequent. So, and unless, and for example, another obstacle is just to convince all primary care doctors that diabetes is not just, like you say sometimes in Britain, a mild touch of sugar, or just nothing really serious, it doesn't cause any pain or anything. But this is the moment to act right now, just because your glucose just crossed the threshold of diabetes diagnosis. So also working with the doctors is also, because I understand that from primary care perspective, we are somehow, it's like a market for chronic diseases. So we have to market diabetes better, because we compete with other chronic conditions you have. So for us, diabetes is everything. For you, it's just one of the.
But that's exactly the point I've raised previously, and that is, what about fear arousal? Now, our cancer colleagues have worked because people are frightened. They will go for a prostate check, a mammogram, whatever. Heart disease, people will take a statin, they don't feel any different, but they're frightened of heart disease. But then diabetes, oh, my grandmother had it, she was 90. We have data from my group, if you're on dialysis. If you're on dialysis as a consequence of end-stage renal failure due to diabetes, and you've lost toes or part of a foot, your outlook's worse than every cancer in terms of morbidity. We've got to raise the profile, and also politically across Europe, that diabetes is a serious condition that needs to be taken seriously, just as cancer and heart disease.
We've been working on it for years together, and there is some improvement, I believe, but it's really, really slow. And we compete with other more spectacular conditions.
But I think that, okay, the patient is the person. I mean, the patient, we know that those citizens over 65 years old have around 5 to 6 chronic conditions. And we have to take this into account, because when we are trying to help a citizen with that chronic conditions, of course we have to be very informed as a primary care physicians, or primary care professionals, all of the other conditions, and how we have to prioritize our actions to be affordable for them to cope. And also all these emotional aspects, all of these familiar aspects, some aspects that has been discussed in this meeting, how the family could be important to support them, to coach them. So many, we have these contacts, but sometimes the contacts we have with them are very focused on therapy, on actions, on A1C, but there are many other aspects that are there on the basket that maybe you are not paying attention. And there are some studies that reflect that. For example, the Down 2 reflect that the perspective that have the professional compared to the perspective have the patient is completely different in some domains. And we are having also to try in primary care have a good opportunity trying to match better the expectancies from the patients, and we are healthcare professionals in primary care to be more aligned with that, what are our citizens with that chronic conditions expecting from us. And also at the same time try to build bridges, try not to be like isolated. It's not like primary care, secondary care. It's a continuum. And I think that I fully agree that in my country it happens the same with primary care. It's like elementary medicine, because our systems, whether or not, are really hospitalized centered, and university as well. And of course, the real life is the majority of the citizens are visited in another ways. It means that the hospital is amazing. We have amazing hospitals and resources, but we need to use it in the very limited situations. But the majority of citizens are care and must be visited in another level. And I think it is very important for everybody, for the scientific community, for the healthcare community, and also for the citizens. If the politicians provide value to the primary care, that is essential, because everybody understands the importance of that level of care.
And the global problem probably is that the modern medicine, the healthcare systems did not follow quickly enough what modern medicine can achieve. We people, the government, still more think about acute conditions. So this is what you need, hospitals. And we are very good in saving people's lives when they have myocardial infarction or stroke. But then this has been well cared for or looked after. And nowadays the major thing is chronic diseases, and it is very nicely reflected by the term that we are encouraged now not to say diabetic patient, but a person with diabetes, an individual with diabetes or living with diabetes. So you have a chronic condition, but you follow your life not as if you didn't have it, but with it somehow, but successfully, equally successfully. And the systems are not ready for that, because you will never die from myocardial infarction really if you have it in a center of Barcelona, Manchester, Warsaw, wherever. Yes, but you may go with undiagnosed diabetes for years, still living in a city of our centers, in a center of our city. So it's that's the challenge, much beyond medicine, and without, as Professor Boulton said, politics, but we are trying to raise the awareness, we won't be able to succeed at all.
And education you raised is an important point.
At every
The
level.
problem is, and there was a study in my area of diabetic foot, that we all have to sing from the same hymn sheet. And there was one example of leaflets out in a waiting room that give conflicting advice. And I think in terms of education, we need to be uniform across primary and secondary care to make sure we're giving the same messages. Otherwise, we're lost.
Exactly.
Thank you very much.